This podcast is sponsored by Pax. Whether on the water, on land or in the air, Pax bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. Pax bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. They're designed with infection control in mind and are easy to clean and disinfect. So highly visible colours and reflective strips aid quick identification and adherence to quality standards, ensuring reliability. So the versatility of Pax bags caters to diverse EMS providers, and they deliver vital equipment, durability and ease of use for pre-hospital critical care services globally. I've used Pax bags in a number of critical care situations, and they're absolutely excellent, both in identification of kit, but also in identification of the reflective strips to ensure visibility. So please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking about the future of AI-enabled healthcare. So what we're going to do is do a deep dive into how the concept of artificial intelligence is revolutionising how we train for critical scenarios and indeed critical skills such as CPR. What we want to do is really look at how traditional simulation training has long been plagued by challenges such as limited realism, high costs, and indeed barriers to entry such as accessibility. But now, the advancements of AI, particularly through ChatGPT's new advanced voice mode, or AVM, are offering transformative solutions to those problems. So by simulating patient interactions with emotional depth and natural conversational flow, AVM promises to bring an unprecedented level of realism and inclusivity to medical training. So in this episode, we're going to explore the technology's potential to modernise education for both trained and untrained medical responders. We're also going to look at how AVM can enhance older manikins, relive or indeed revive the trainers from multitasking, and indeed deliver just-in-time learning opportunities to participants. We're also going to tackle challenges such as minimising AI errors and indeed mastering prompt engineering. So join us in this episode as we explore how ChatGPT is shaping the future of medical simulation and indeed making training more dynamic, equitable, and effective for healthcare providers worldwide. So to do this, I'm joined by Luca Carenzo and Federico Barra. Both of you are experienced clinicians within your field. Welcome to the podcast.
Thank you very much for inviting us.
Thank you very much. It's a pleasure to be back on the podcast.
As it is the first time, Federico, could I just get you to unpack your experience? Luca has been on a number of episodes with us. Could I just get you to speak to your background?
I'm Federico. I'm a critical care consultant in Italy. I work at a university hospital, and university hospital also has a simulation center where I do a little bit of research in debriefing and lately AI. So what you probably expect is something about AI in our latest publication. So I'm happy to be here and share some ideas.
No, that's fantastic. And I think we'll dig into both your background, but also, like you said, publications and your insights into how AI is changing the medical training ecosystem, really. And I guess my first question on the back of that, and Federico, I'll come to you first, is why it's critical, really, to enhance training methods such as CPR, but for both lay people and so medically trained people, and indeed healthcare providers.
Well, you can think about it this way. When someone's heart stops, every second counts. So the quicker CPR starts, the better the chances of survival. And that's why improving CPR training is so crucial. It's not about just knowing the steps. It's about building confidence to act in a real emergency. So AI-driven tools like ChatGPTs, Gemini, or any other tool that will come out in the next years can help people, can guide them, can evaluate CPR performance as accurately as a human instructor. But generally speaking, in a lot less time. So people can train faster, and faster training means that people can you can train more rescuers.
So let's talk about fidelity. And Luca, I'll come to you actually next. And just to talk about some of the common challenges faced in current simulation-based medical training, realism, accessibility, fundamentally fidelity. Could I get you to speak to how AI can sort of leverage and increase and improve fidelity?
Fidelity is a broad concept, is a world per se, where when you think about fidelity, you think about physical fidelity, and physical fidelity is what most people tend to focus on and invest in having the latest simulator, the most realistic simulator. But that's just one bit of the fidelity that is needed to engage the learner, because that's the key. To have an effective educational intervention, the learner needs to be on board, needs to be engaged. And you need physical fidelity, but you also need conceptual fidelity or psychological fidelity. So these three, and in conceptual fidelity, we have the way we interact with the mannequin, and also what the mannequin says, regardless it's portrayed by an actor, instructor, or now AI, is actually something that it's faithful to what the learner expects to learn. And you can imagine that if we can have a realistic, natural language AI interacting with the learner, this could actually be a very interesting step forward in the field of fidelity as well.
No, absolutely, absolutely. And to your point around interaction, almost having to and forcing non-technical skills as well as technical ones in a way that you are starting to, but also see the implications of good non-technical skills, but also the manifestation of your treatment. So actually, the AI could hopefully be responsive to the treatment, so that the physiology and indeed the pathology changes according to your treatment, and you see that in real time. Federico, I can see you nodding. Could I get you to speak to that as well?
Yeah, I mean, physiological fidelity is a very big issue, and it goes back since the very first high-level mannequins, like in the 2010s or something like that. So those mannequins were they had some models that can change according to some sort of physiological parameters. So not just the instructor changing the parameters, but also the trainees' inputs can um, um, change the parameters or change the mannequin response to directions. So that is an adaptation of fidelity, like in the real world. But AI can do a step more. So it can also, as Luca said, you can go with psychological fidelity and also physiological fidelity, both linked together and in a powerful way.
So, Luca, one of the rate limiting steps in the past, and I'm sure you've interacted with this, is some of the socioeconomic barriers to entry. So, social deprivation or just even access, and also some of the anthropological factors just around medical training globally, certainly in developing countries where there's maybe not the access to the fidelity or indeed to these, like you said, expensive mannequins. Could I get you to speak to how AI is changing that narrative or indeed that discourse?
Yeah, absolutely. Actually, the idea to mention this topic in the paper came from even not training, but the real application of clinical care. Because there is research that demonstrated that specifically regarding cardiac arrest, there are populations that we could define underserved populations or segregated populations that are less likely to receive bystander CPR. And this is widely published, both from, say, gender issues and socioeconomical issues. Now, it's likely that this also reflects training. I mean, it's more than likely because it's not only gender and socioeconomics, but it's also, accessibility of education. And as you said, the different countries might have different resources. Now, imagine if you could, if you have the nice mannequin and you want to add a step extra, then you add, the advanced voice mode we are discussing. But imagine you have a classroom of medical students in a country that cannot afford a very expensive mannequin. You can implement a simple Bluetooth speaker with a basic life support mannequin, very cheap, or even a box, and try to modulate relational training, like history taking, through a simple tool like AVM. And I'm saying simple because for the end user is simple, not because of course it's very technological, but in the end, to the end user, it can be easily trained, it can be easily applied. Also, there are limitations, we'll talk probably later, but there are limitations, but let's think about the future and that these are tools that will keep being developed.
So Federico, let's bring this to life slightly for listeners. And just if you could just speak around specific tools such as ChatGPT and how they play a role in addressing the constraints of traditional medical education. Could you maybe speak to, yeah, just indeed the interplay or indeed interface, how it might look in reality using ChatGPT, as Luca was saying, with maybe more of a fundamental or indeed basic life support mannequin?
Well, so the use of ChatGPT applied to mannequins is an idea that Luca and I shared, and we eventually published it in a very practical way. So we designed a way to interact with a device with ChatGPT and a Bluetooth speaker, or with a mannequin, and so they can be linked together. And I mean, and they can be useful to simulations. So ChatGPT is a text editor, is a text generative AI. So basically, it is designed for that. So it is since the release of AVM that we tried some simulation in Italian, so some dialogues between users, between patient and doctors, between residents and patients and something like that. So before that, it was a very basic voice, like emotionless. So it's better than nothing, but it's nothing like what we have right now, and it's expanding. So I mean, we in our article we tried, and we shared some experience with ChatGPT, because that's like the most commonly known and the most probably multimodal generative AI that everybody knows right now. Like in a couple of years, it's become probably the best known generative AI, but it's not the only one. So Google Gemini is almost there. As functionalities, Gemini is doing like the same as ChatGPT. The only difference, and it's free, of course. ChatGPT has a little fee for the creator, let's say, not the end user. For the end user, it may be free with just a registration, but for the creator, they ask a fee, and for the use of unlimited AVM, the fee is like $200 a month, which is a lot. Anyway, for $20 a month, which is the subscription that Luca and I bought, you can have a couple of hours of AVM per day, which so far is enough for us. Gemini has everything that ChatGPT has, but the natural language and the emotions. So it's almost there, not right there. And there's also other conversational AIs that are available, like 11 Labs has like some sort of conversational AI agents. I tried it lately, and it's really, really impressive about that.
So let's dig a little bit deeper, actually, and just look at something the article which you yourself, Federico, and Luca wrote, and just to give an explainer really around standard voice mode, so SVM, and indeed advanced voice mode, AVM, and their respective roles in enhancing medical simulation. Could I get you just as an explainer, just to unpack it for listeners?
Standard voice mode is basically a prescripted responses that follow a fixed path. So you can shape the way the model reacts, the model talks. You can give a past medical history, some information about the patients, and at least in English, it works. I mean, it's not excellent, but it's good enough. In Italian, not at all. So the problem with every generative AI is that the core, the huge material which they are trained of is in English. So it's not excellent in other languages and other accents, etc. So, but you can pre-train that. You can create some in ChatGPT's and ecosystem. It's called a GPT. So basically, a model that is trained on your data, on some documentation, on some backstory, on some other prompts. And you can pre-design that. So, or every time you start a chat with a GPT, the GPT reacts most of the time, like 99% of the time, according to what you prompted. AVM is a step further. AVM is another thing. AVM is very good at natural language. You can prompt the model to respond like as a panicked, as a anxious patient, as a old guy, as a 4 years old. So you can really get the best of the voice models, and you can tell the model basically to respond in any English accents that I know, at least, but also we tried it in Italian, and it goes. It has a very good Roman accent, and from Naples also. I mean, it's very good. Also a very standard Italian, but with emotions, which is really good. The problem is that you have to prompt the model by voice. So it's what we do is we give the model a prompt by voice. Then we put the Bluetooth speaker in the room with the microphone off, and then we remotely control the microphone on and off time. So when the participants enter the room, we can control when the model gets the audio, because emergency simulations can be very noisy. There can be a team talking to each other, so it's difficult for the model to understand when they have to respond.
So you both practice critical care, actually, and I'll first aim this question to Luca, but come back to you as well, Federico, because you've just notioned towards something very essential there, which is, the essence of what essentially what Luca was saying earlier, which is the increase in fidelity, both emotional fidelity and physiological fidelity. So the mannequin through the AVM, so through the advanced voice mode, can start to really react to the prompts and indeed to the medical treatment. And what this initially sort of mimics, which Luca was notioning towards earlier, is this analog of reality, which is that actually when you practice formulaic CPR in a controlled environment with no emotion, with very much stable conditions, it's fine to be able to rehearse that, but that's not an accurate reflection of reality. And actually, what we see is skill degradation and indeed skill decay, and indeed lack of maybe sometimes compliance to skills when the human factors come in. And you both work in critical care, you've both been subject to impending human factors, both from the environment, from patients, and from the wider scene. Could I get you to speak, Luca? Could I get you to speak to just why it is important, really, for applications such as this advanced voice mode to really start to increase the the emotional nuances, the accents, the languages, and some of these human factors which are almost mimic what you'll see in reality?
Say in the optimal world, so what we aim for in the future is basically we'll have an experienced human factor trainer, because training in human factors, requires a lot of effort, and also requires a lot of, especially within an organization, you might want to have sort of a standardized approach to a competency model, that is how you apply your human factors into practice. Now, imagine if you could sort of roll out a standardized training based on your organization competency model that you might have fed to your AI of choice, let's say ChatGPT in this case. So that's the next step, because what Federico said is that at this stage, and the way we did the research for the letter, is prompting by voice. And prompting by voice is a bit of a limitation, because different voice prompts might produce not reproducible results. And that's one of the things that we're working now. But we do expect, of course, we cannot be sure 100%, or we do expect that the natural step forward is to allow the ability of implementing GPTs defined as these containers, where you can sort of limit the information that can be sort of that trains the model, combined with the advanced voice mode. And this would allow also let's say a quite scalable training for all the conditions we said before, all the situations we said before, especially where these usually would not be available. And moreover, I'll add a small word that maybe will come back later, which is trainer, which means not only teaching, but also providing feedback.
I think that's critical. I think that's absolutely critical, because feedback is fundamentally how we all learn, and actually certainly as clinicians, but also as lay non-medical trained people, there's an element of feedback is actually super helpful, and can allow an individual to course correct it contemporaneously, so in the moment, which is extremely important. Federico, to you.
Yeah, I totally agree with Luca about what he said about the possibility in the future. I mean, the the pieces are there, and I think that the future will go in that direction. So we can I mean, we can both pre-program the model and obtain an interaction with the advanced voice mode, and that will be a very good implementation in the future. I hope. But anyway, I mean, as I said before, ChatGPT is one of the players, is not the only one, and the competition usually in these fields is really good, because as end users, we will benefit from competition. And we saw something like similar, like in the past week, where both Google and the OpenAI presented the fact that both their models can interact with also video. So from the phone cameras, the model can also not only talks with advanced voice mode, but also can see something that is presented before. So it is not yet available. I tried it, but it's not yet available for to me, at least. I think in the US and other countries is a little bit more is available right now, but we can't wait to test it, because if the model can also see, I mean, we had a very good interaction with some residents and a mannequin last week. And the feedback I got from the residents is that, I mean, they are all experienced residents, trained as trainers, so they know the backstage of simulation, what is needed to run a simulation in the control room. So they said, with this mode, you talk to the patient. you forget that you are in simulation room, and you don't do like when you don't get an answer from the patient, you know that something is wrong in the control room. The structures may have some, I don't know, some troubles, and you talk to the air because you expect the answer from the speakers, not from the patient. With the advanced voice mode, they talk to the patient. They just do that. And one interesting thing was that they were assessing the abdomen of the patient, and they say, if I touch here, are you feeling any pain? And of course, the mannequin responds randomly. So and I told them in the debriefing, if you don't tell the mannequin where you're touching, you just get a random answer. So it can be right or wrong. You don't know. But in the future, with a model that we that see, so we can link a video camera and the advanced voice mode. The model can see where you are touching, so you can also train that, and it will be very interesting to see that.
Yeah, no, indeed, absolutely. I've just spoken with a company in the Netherlands actually, and it will be part of this series actually, whereby what they've done is they've integrated XR, so extended reality goggles, onto a mannequin, and embedded AI into the system as well. So what you're seeing is very much to what Luca was saying around, a very basic mannequin, but they've it through the goggles, you now see the facial expressions, you see the pallor, you see the pain or the expression of pain, and with the generative AI in the background. So, and the AI is being prompted, but then what you get this sense of is the physical fidelity in front of your face, with like mapped onto a very much a basic mannequin, together with the AI prompting, so that it's starting to, like we said before, increase the emotional fidelity as well, and the physiological fidelity. So you're starting to get this real meld of extended reality, from very primitive models, very primitive mannequins, because actually it overlays all the imagery to the goggles, and then with the AI embedded, it's extremely powerful. Um, Something Luca said earlier, which is really interesting. Having worked myself in Somalia and indeed in Kenya and in sub-Saharan Africa, where in a medical school context, you could just have a very much barrier to entry is really lowered by having maybe a very just primitive fundamental mannequin, and then using this generative AI, using AVM, so advanced voice mode, to really start to improve the interactions. Could I get you to speak to that? Because I'm sure there'll be people listening to this where you could actually quite easily tomorrow go out and start to really build a high fidelity simulation based on some primitive technology.
Yeah, I think the first step is familiarize with the technology and do enough training to be sure that sometimes there might be answers that do not align with what the instructor expects, and that is why voice prompting is fundamental. So I think that's the first step. Meanwhile, we wait for a release where we'll be able to integrate GPTs, as I said before, because that will probably change the game significantly in the field of medical education.
They are called agents, and I think that they will be released into 2025. But I mean, we cannot be sure about that. But that's the future.
And from a technical perspective, I think any instructor should sort of familiarize a bit with the setup, but the setup can be very simple. So in the tests we did with Federico, we used a Bluetooth speaker, which also included a mic. So it was a single small box that you could position anywhere, and then you could control it via your device, which could be a tablet or could be a mobile phone. Because of course, say prerequisite for this is to have an internet connection, but internet connection is fairly available in most of these countries. It might not be cabled, it might not be, but it's fairly common to have at least a 4G, if not 5G, internet connection. Now, that would be the most simple and basic setup. Then you can both integrate ChatGPT, AI, AVM in a more complex simulation lab. And you could have the overhead speaker talk, which is something that happens in simulations. Not a big fan of it, but happens. Or could, with some mannequins that have a speaker in their mouth, connect that to the audio output of your PC, or modify the mannequin. We cannot really actually say promote that, because modifying a mannequin can void the warranty and all of that. But if it's an old mannequin, like a BLS mannequin, actually install the speaker inside the mannequin. And that's something that probably should be discussed with a simulation operation specialist, if that figure is available to the instructor.
Let's talk about limitations, actually, if that's okay, because we've both notion towards the limitations of voice prompts rather than maybe written prompts, so that actually what you can do is maybe in the background really start to train the AI so that actually it comes to, because I think what we're fundamentally after here is alignment to the ILOs. So if you have a specific intended learning outcome for a simulation, that the AI gives a semblance of reality, but it also comes back to and aligns to the intended learning outcomes for the simulation. It might be compliance to a technique, it might be practicing some of the fundamental endpoints of that technique, but it also might have various assessment skills strewn through it. And it might just be involve medication and some of the pharmacological agents that you use. But could I get you to speak to some of the limitations, such as training the model to align to ILO, to the intended learning outcomes, or indeed some of the master prompt engineering in the background that still might need fine tuning to really start to give you a semblance of, or indeed the trainer a semblance of control, really, that it does increase the fidelity, but it still aligns with what the trainer wants to get out of the session?
There are a lot of limitations so far. So we experimented a little bit with models, and we experimented in different setups, both in a simulation room and at a conference. And so basically, the first one is that it requires precise voice prompts. So you need to test different approaches, write those down, and try a lot of times before going to a simulation room with some trainees, because it can go wrong. So the model, what we saw is that it tends to give the emotions, like speaking about the emotions, like I'm talking with anxious, with some anxiety, and then starts talking. So what we do is fine tune our prompt, see what the AVM responds, and then fine tune it before going to the simulation room. One pro is that once you get a good interaction, you can restart that interaction. It usually restarts where it should begin. So you try and get some response, and then you go back, and then at that point you go into the simulation room. So that's the first limitation. The second limitation is time, because you have a couple of hours per day with the standard $20 a month. And I think most of the users of ChatGPT has that kind of subscription. I don't see anyone, at least there's a very big center, who is paying $200 a month as a for private use. I mean, not in Italy, not right now. But so money for the standard $20 a month is not comparable to buying a new mannequin with some sort of proprietary AI model. Luca and I, we are end users. We are not engineers. We use what the technology offers us, and we try to shape it to for the instructors. So another tricky part is where the teach the model to understand when the team is talking to the mannequin. So we tried a way which is like hey Google or something like that. So you call the mannequin with a name, and you tell it tell him or her that it needs to respond only when he hears something like hey, I don't know, Patricia, hey Leonardo, hey something. So it doesn't respond with random words, random sentences otherwise. So I think, Luca, I don't know if you have other things in mind.
Just about this last thing at the moment is good for one-to-one interaction. We're still experimenting with the team interaction, and the trick that Federico just said is specifically for teams. But then it requires the participants to actually use part of their bandwidth to always remember to talk to the simulator by first name, which is a bit of a limitation at the moment. If the conversation is one-to-one, no one else is in the room, that it's no problem. But if even there's already a nursing personnel, then you need to start using names or something, and need to train the model to reply only when interrogated by first name at the moment.
Yeah, and for emergencies, one other tips is get a Bluetooth speaker that you can control from the control room or from remote. So if the patient becomes unconscious, you can just pause the mic and so the patient doesn't respond when it's not supposed to respond.
I think that's fundamental, not only for emergencies in general. Having a speaker where you can selectively control speakerphone and microphone remotely, I think it's basic for testing this tool.
Yeah. Also, if you hear that the model doesn't respond appropriately, you can just disconnect the Bluetooth speaker, just give some other prompts, and then go back to the remote audio. So
yeah,
you can just impromptu training. Sorry, Luca.
No worries. I think because we've been experimenting with disconnecting the Bluetooth speaker, I think if you can afford having a mixer or having a small switch, then having two mics connected might make things much easier, because then you can have a mic in your control room and the mic from the Bluetooth speaker, and then you selectively can cut open one or the other. That's sort of a setup, gold standard, high resources that we're actually testing at the moment. So you don't have to disconnect, prompt, reconnect. That wastes time. There might be the risk of not pairing correctly. So the ideal would be to be able to feed a secondary microphone through the system while having excluded the primary microphone.
Yeah, absolutely, indeed. And like you said, to all these iterations and improvements in the system, I think something you both echoed really, which is also really important, is this semblance of feedback, and not only feedback from in simulation, so that actually the AI tool is starting to give the learner or indeed the user feedback, positive or negative, that things are actually improving for the patient like they would in real life, but also feedback in debrief, so that actually there's maybe capture of information, capture of data points, capture of maybe key single point decisions where things went better or worse, things that so you can start to really hone in on good practice and areas of good practice in the debrief. So and I guess that really is a question more so than a statement, because I'd like to get from you where you see the leverage points for the future from a generative AI model embedded within a mannequin, could both in contemporary practice but also in the debrief. Could you see, do you see this to be sort of equally weighted and sort of push forward on that basis? Federico, if I could come to you.
Well, one thing that Luca said before is that not every training center has, I don't know, simulated patient, standardized patient. You need training, you need money to train them, it takes time, and you don't always have them with you. So a mannequin that can interact with you and gives you feedback at the end is, I think, it's a very valuable asset in a simulation center. And we tried that. So if you interact, you have a natural conversation, I don't know, history taking or anesthesiology history taking for surgery. You get at the end the possibility to pause the conversation. Then in the debriefing phase, you get I don't know, the your phone, your device, and you start that conversation again. So the memory of the conversation is in there, and you can ask that to the model to give you a feedback in any way you want. Meaning, you take a score, you take a scale, you take an output that you want, a framework, I don't know, dash debriefing or just feedback, the Ottawa global rating scale for non-technical skills, something like that. Of course, the limit is that the model guesses everything from a conversation. So far, it cannot seize you, but I mean, in the future, possibly can. So you get the feedback, and the feedback is automated feedback. So it's not. We have to test the psychological safety of the participants with a machine giving feedback in natural language. But of course, what we do in our simulations, that when you have a simulated patient, a standardized patient, you get their feedback too in the briefing, and you can give voice to the mannequin, which so far was voiceless.
Indeed, I think that's powerful. That's powerful because, like you said, it gives this reciprocity, it gives this two-way interaction, which mimics, like you said, real life, real clinical practice. Luca, to you, where do you see next steps and sort of leverage points?
Well, I think what Federico said about feedback is fairly interesting. We tested it a bit, and I think need to separate, the feedback that is given from debriefing conversations. They're very different things. So at the moment, when the machine has reference model framework, especially if the framework is very simple and it's about conversation, like Federico uses a lot, the Calgary-Cambridge model. The Calgary-Cambridge model is a structured methods to assess medical interviews. And it is like, has he initiated the session by greeting the patient? Has he gathered information? Has he closed the session? And now that's fairly, easy to gather from a conversation. We had very interesting feedbacks testing specifically the Calgary-Cambridge model, especially because the AI can keep track of all these aspects. Well, an observer could struggle, take notes. Has he greeted the patient? Yes. Has he gathered information? Yes. So this is very fascinating. I really, really am looking forward to actually investigate more simple tools, structured feedback. Now, if we are talking more about debriefing, I think it's a whole different level with a whole different ethical implication. I mean, there's an ethical implication in general. We're talking about learners, potentially vulnerable subjects. There must be a degree of psychological safety. The feedback, even in the Calgary-Cambridge, the AVM will give, a straight feedback saying, you entered the room, said, what's your problem? You could have greeted the patient. It's very, of course, blunt in a way. So then we can discuss whether this should be, the instructor should listen to this and gather the information in a structured way, or this should be listened by the learner. That's to be discussed. Surely a conversational debriefing, it's something that probably requires a lot of further research, ethical considerations, and also, a different learner that is probably knows what to expect. But this is for the future. This is pure speculation at the moment.
I totally agree with Luca about that. So so far, also the EU regulations for AI basically tells the users to supervise any interaction with machines and learners. And our university also has a strict policy about that. So we are not allowed to let the learners alone with AI in a very, it's powerful interaction, but it can be also a problem if the model responds in a strange way. It has hallucinations. So a learner cannot understand when the model hallucinates. So a tutor has to be there.
Yeah, indeed, it is a whole new world actually. And I think what we do is I'm going to put the article, the fascinating article that you have both written as a letter to the editor. It features in the Journal of Resuscitation. I will put that in the show notes so people can read it because it is fascinating. And indeed, you go through the nuances of AVM, ChatGPT, and also there's a fantastic just diagram in there around for people that want to really unpack this further, and just a few images as to how this might work practically and in reality. So I'll include that within the show notes. But it is such a fascinating, evolving area of study, and like you said, the scope for further research is wide. But it's also to both of your points, really fascinating how quickly the adaptation and indeed the technological advancement is occurring, which is great to see. And the scope, as you both said, to vast improvement, both in the domain of real-time feedback to the learner, and then also debrief on the back end as well. But listen, I just want to thank you both for your time. It's been fascinating talking to you, unpacking this article. We'll put the letter to the editor in the show notes. But thank you,
also
Federico.
have a video if you would like, a short clip demonstrating its use. I think it could be a good addition for the.
That would be fantastic, Luca. That would be fantastic. Actually, we'll put that in the show notes as well because I think the more information and the more resolution we can bring to this, it'd be the better. So that'd be fantastic.
Yeah, we recorded a little bit of interaction with a standard inanimated mannequin in our training center. So you can see and it's not cut, so you can see all the conversation flowing naturally. We try to respect the flow of the conversation without any cut that can, I don't know, like, okay, but you scripted that. No, it's just flowing.
I think it's really important actually because, like you said, the adage here is that we want people to be able to both replicate not just the study, but replicate the interaction and embedding AI into such as ChatGPT. So it's nice that we can allow people to see that as well as to read that. So that's fantastic. Thank you to you both. I really do appreciate your time for this past hour. It's great just to unpick this. I do think it is the future of simulation, both hospital and hopefully out of hospital for full training and indeed simulation. But thank you for both of your views today.
Thank you. Thank you for inviting us.
Thank you so much. It's always a pleasure to be on the podcast. Thank you.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.